Satyapriya, Satish, please take over. So Ganesha, would you like to join with them also? It will be privileged. So you feel whatever your thought process, please feel free to. Dr. Govindraj is here somewhere, so he'll join also later. Can I have the slide control? So we say, because this is both from preventing the complication from the patient's safety perspective. Second, safety of us also from the medico-legal perspective we need to see. Because when complication happens, it is also patient is suffering, you are also going to suffer to some extent, whichever way we'll find out. So we need to, whether to name a complication as a complication or term it as unplanned events. Because there are slightly things, because when they say complication, that means medical negligence. They compare it to medical negligence. So we have to ensure this happened in spite of giving the best standard of care. So in spite of the treatment best, so that is very, very subjective element that we need to see. So the wording, which terminology we should start using? Can we use the best terminology to explain all the adverse events happening? Is it whichever way? What, Professor Sir? Speaking. Give the mic.
I think in view of the present medico-legal cases that are coming against the doctors, it is better to use the term unplanned events so that the responsibility of ours on something going wrong is much, much less.
I totally agree. Unplanned events, we all should agree
It's
to
like
write it is the
adverse
unplanned
effects for
event,
the
no
drugs.
complication.
Instead of, side effects is better than adverse effects, the way they say. Because adverse means something already, side effect means there are every medicine has an effect and a side effect. Like that we say. So every procedure as a planned event is getting recovery. Patient is getting better. Unplanned is this is happening. So use the word. And why it happens is the next important question. We all know it is a three from. One, patients are the fault, that is high risk patients, or the procedure itself is high risk procedure, that may be the reason. And third, of course, is the most important thing, crux of the matter is we are the team as such. When I say the team, both the surgeon and also the team as such may be inexperienced. So that's only the coming for the credential or training. Now the important question, can we do endoscopy? That is a fundamental question asking. As a surgeon I am asking, can a surgeon do an endoscopy? And how many endoscopy one has to do before he can claim himself to be competent? I haven't touched endoscopy I have come today for a practice. How many I have to do before I certify myself an endoscopist? Having an Efiages, whether it will make me medico-legally protected. These are the questions asked by them. So what's the answer? Comprehensive answer for this three anxiety questions.
Surgeons can do endoscopy, there is no question in it. Ultimately, it has to come into the postgraduate curriculum. So somehow or the other it has gone to the medicine side, but they have to learn it. And there is no shortcut of learning. If it is not in the institution, EFIG is just a one step to it. So you have to get used to it and then go for more training, maybe 3 months, 6 months, or do under somebody's supervision. At least 50 endoscopies, upper GI endoscopies should be done by somebody. Then only he can claim. And then we have to just not only know the procedure, we have to know the pathology as well. We have to be able to recognize the pathology, then only it is complete.
Good. I think it's more or less common. What we are trying to add on to that is try to maintain a logbook. Logbook is not during your postgraduate time. It has to be a continuous lifelong process. All the things, because when the court says how many such cases you have handled before, they ask several times, especially when you do some unusual like poem when it comes, they'll ask you how many you have done, how many you have seen, have you gone through, because they are going to get an expert to witness and he is going to ask, ideal world, this is what happening in the other countries like in America. What they do, they go for animal model experiment, either a live tissue or a live animal, next patients under supervision of mentor, then you do with the mentor you do certain cases, then individually you do. So that path, have you traveled that path, they are going to examine that you have to take. So I think we are all sensible people. We need to make sure you collect all the data, like Efiages certificate, any other certifications, keep on adding, maintain a logbook, and maintain a case record, whatever case you have gone through problem, and if everything is proper, the court I think will see that it is unfortunate, in spite of the best standard of the care and the best of hands, this happened. This is what you need to prove, the proof. So we need to fight for our rights. The association will strongly back you up. As an Efiages member, I am sure if one of you get into trouble, the first person to come forward, I am sure Efiages, apart from any other association you are associated with, they have, I mean insurance, or they are also going to support. Anything else you want to add, sir?
Ishwaramurthy, I can tell you there are a number of people with just MBBS doing the endoscopies. Now they are doing therapeutic also. In Chennai, I know at least 4 of them are doing it, but they do not come and present their papers or anything. So the qualification minimum, I think today will be MBBS. And from what I have read in the papers today, they are going to introduce this into all the Ayush hospitals who are not MBBS but are from other category of medical treatment.
And the final question on this topic I wanted to ask, because ideally the American college has recommended 20 to 25 cases of upper GI endoscopy one has to be done before you certify yourself, in American board at least. That is what they say. But we got now higher end, not live patients, we have a simulation. I think Gani Bhaskar Rao, he could answer whether by doing 100 upper GI endoscopy in a simulator, then we can do less number of live cases. Well, that will be considered as a satisfactory certification process.
Definitely, I think in future with the simulation only
Where
they
do I
have
join,
to,
please?
they have to enter in the clinical arena. That's why the simulators are best enough to instead how many times they can do it as they like it. And that more experience and less time, more comfort to the patient. Including the patient feeling also, you know that how the air is more put just where the pain and everything. That's a good attempt. I think it may go to regulate in short time. We will request the government also to get it trained in simulators.
So simulators definitely useful. They will shorten your learning curve. There is no doubt about it. So I think that is the way future. The future is simulation to large extent. So we need to take it on your training fold. Okay, that's about it. Coming to the timing, one of the things happens is due to the drugs we give. So who gives drug? What are the drugs you are competent to give? That is a common thing. For example, in endoscopy room, I like to have following drugs. For example, to sedate the patient, a conscious sedation, we give midazolam, diazepam, occasionally propofol, usually propofol in the presence of anesthetist. For analgesia, we give tramadol, for example, we give tramadol, or we give fentanyl sometime, ketamine occasionally. So these are the drugs we give. And other drugs is adrenaline should be available, and buscopan we use. So these are the common drugs. Any other drugs we need to keep in the, or what are the things required in the endoscopy room? Drugs wise or any other things, because we are going to handle the drugs, whether are we competent to handle the drugs or you need the anesthetist. When you expect the anesthetist to give the drugs?
I think monitor also should be there in all the colonoscopy cases. I always make IV line because one of the cases in West Bengal last few months they have made a different committee of states. So 2 of my friends are there in the committees. They have said that one endoscopy should in a small places from MBBS was not question of MBBS. They have done whether in the same table they used to do some X-rays and rest of the time they do endoscopy.
Shot injection. Is it acceptable practice, or you think a Venflon or venous access is a good practice for the future?
I think venous access is a good practice. If something happens immediately, we can push the other drugs in those cases. Because of making in a collapsed patient, making that sometimes takes out a very valuable time.
Particularly for colonoscopy, I would definitely prefer to have a venous access because the chance of perforation is always there, and so in case of emergency, we need to have a venous access, number one. And ideally, if the availability of an anesthetist is there, better to have an anesthetist if you are venturing on any therapeutic procedure. For a diagnostic procedure of an upper GI, you don't need an anesthetist. But any therapeutic procedure of an upper GI or colon, definitely an anesthetist should be needed. And a venous access, particular, I feel that it should be there for any colonoscopy also.
Okay. So, I think coming to the venous access, nobody will decide. I mean, when the problem happens, they will ask you, have you had a venous access? Until the time, the issue will not arise. That is a thing. During the process, if it takes longer than your anticipation, you may have to have additional dosage. That is why more than upper GI diagnostic, colonoscopy, very often you are better off having a venous access. That is what, and most of the time in hospitals they admit the patient for preparation also. As well you do, because hydration may be a part. Elderly people, you should hydrate either before or after. So, I think venous access is not a bad idea. I think you have to have the good practice. You want to add?
I feel that oxygen should be available in any endoscopy.
Yes, yes. Resuscitation trolley should be within the reach. O2 should be available. I think nasal cannula
and a nasal cannula and a O2.
Yeah.
While doing an colonoscopy, if the patient has a rise tube, it has to be removed, because during the pressure, if the patient is been prepared on the same day in the morning, there is a chance he will be having some amount of that peg leg or any sort of preparation agent in his stomach, and while we are doing the manipulation in the colon, there is some pressure on the stomach also by the colon, by the endoscope, and he will just regurgitate it.
Okay, thank you. And as you can, I am sure there are umpteen number of books to tell you what are the complications one encounter during all this diagnosis. But main thing is, you should say the common things are common. The cardiorespiratory events, patient going, because as soon as you go, they withhold, so they will go for a respiratory depression or some hypoxia, or sometimes even cardiac arrhythmias or even cardiac arrest. These are real probabilities rather than perforation bleeding, that usually in a diagnostic setup is unlikely. So, you have to make sure you are aware of these complications. That is why we need to know clearly when you have to be very careful or contraindication. What are the contraindication of endoscopy? We will come to that in a minute. Coming to the cardiorespiratory arrest, have you come across on the panel? I will open the question. Have you had any bad experience of patient collapsing on the table with no pulse query, BP query? How you got out of? Tell some good stories. I don't want the bad. It's a good story. How you come out of the problem? Any Govindra, you want to?
Yeah, it's not a good story. It's a really bad story.
Okay, tell me.
It was when I started endoscopy after coming off from Kisharao. I had for a regular upper GI scopy. The patient got out of the couch, dropped dead. We couldn't resist it. In fact, we had the whatever all the paraphernalia
after the procedure.
After the procedure, then we went into the books and we found out that it's a syndrome called the sudden cardiac death, which can happen anytime. So there is always a mortality of not 1%, even in upper GI scopy also. So that you have to keep in mind. So consent should be obtained. That's what I come to infer from that case is, always a consent is important even for a simple diagnostic endoscopy also.
Yeah, written informed consent is a must, irrespective.
And also should be in the native language, because few of the cases they told after the incident happened, but he told it was written in English and we cannot understood what it was written, we signed it.
What I request all the delegates to explain the procedure. Even the simple anal examination can get the cardiac arrest. Unless we tell them what is the procedure, what you are doing, they little panic and they what is the simple thing become maximum more of a horrible thing. That's why explain what you are doing the procedure. Endoscopy, simplest procedure, how to go in. You can a lot of YouTube, lot of animations are there. You can show, you can just show it and you are more safe.
And one of the common thing I find is when the patient's pulse oximeter is a good practice, have it. In addition, vigilance. You have to be very vigilant, patient is comfortable. But as soon as you feel a patient is not breathing well, pulse oximeter dropping, saturation, the first important thing is take the scope out. Because the anesthetist is not going to tell that. Because there will be, especially if you are a senior surgeon, there will be somehow they are trying to manage. You can't take the scope out, first important thing. That is the first important thing. And ask them to, if the patient is in an awkward place, like left lateral or a prone position, put them on a supine and a flat form, ready for whatever. Because you don't for the bradycardia become a cardiac arrest. So always you have to be very, because we had a recently, last week I had a patient, lap chole, we do quite a few simultaneous lap chole ERCP. Lap chole successfully done, patient is in prone, intubated patient. And suddenly when I do the sphincterotomy, I saw things are letting blue. Why the bleeding is blue? Then I saw the monitor. The anesthetist was, I shouldn't criticize, my anesthetist was busy with something else. So I immediately asked, And the immediately first important thing is we put the patient prone. Luckily, the airway is already under control. Literally, I was doing all the resuscitation, and at the end of the day, we are able to save the patient. So imagine you are doing a good procedure, something, but they will criticize everything. They will start from why you did both the procedure, start from the scratch. Because whenever you do procedures which are not universally done, when you are doing that, and then there are criticism will come. So you have to take all the standard of the care. At the end of the day, you are the captain of the ship. So we have to take the responsibility on the shoulder. We can't blame the anesthetists, you can't blame your staff nurse. You have to take the responsibility. You have to be vigilant all the time. Any other added words?
Can you explain what is your vision and what is the lab coli followed with?
You clear the CBD. So people do a pre-operative ERCP,
Yes.
followed by either same day or a subsequent day lab coli. That is what they do. And because if the person doing both are same, and if you are able to avoid one anesthesia, one admission, you can do. So there are now papers are appearing doing a simultaneous sequence. The sequence vary. One people do ERCP first, immediately lab coli, same anesthesia. We do lab coli ERCP, either way. What's your view on that?
We do the similar kind in our setup, because we do first the ERCP, make sure that all the stones have been removed. If the stones are not removed, we don't subject the patient to lab coli immediately. Once the stones are removed and you are sure that you have put in either a spyglass, or you are 100% sure there are no stones remaining, or put in a stent, then immediately in the same table we do a lab coli also. Another criteria is if the procedure is not more than 1 hour, the ERCP. If the procedure is going to take more than 1.5 to 2 hours, we don't subject the patient immediately to a lab coli. We take at least 2 days for a lab coli.
This is a highly selective group. Like if the patient is jaundiced, more than 5 milligram of bilirubin also, I won't do simultaneous. There are some strict criteria. I think it is evolving area. It is a common practice. That is a common. Coming to the next important thing is a bleeding happening during gastroscopy. As a beginner, because of you keep on touching, you are not going in the middle of the road, you are going and cut. So sometimes mucosal injury can cause, and patient retching can cause. These are all the common things happening. And other things also you should vary. The one thing I am very worried about is when you see a patient with a chronic liver disease, esophageal varices, you should be very, very careful. Because that patient has never bled before and is going to bleed in front of your very eye. And that is because, especially if you are ill experienced, this is the awkward patient to have. How to avoid? For example, chronic liver disease, patient is coming to you for a diagnostic endoscopy, never had before. He had no history of hematemesis or melena. You are in the beginning of your career. Will you take the case yourself, or because anticipate the that's why important. A patient with a chronic liver disease, what do you anticipate and how will you carry on?
No, see, if you do a diagnostic endoscopy, if the varices are not, you don't see any cherry red spots or anything, you can do a regular diagnostic endoscopy. I will not venture to do one therapeutic banding, or in that case, if I am not experienced, definitely. And particularly if you have said that the patient has not bled so far, even our banding might induce bleeding in that, or a sclerotherapy might induce bleeding in that. If I am not experienced, I will not be in a position to handle that. So diagnostic endoscopy, if there are no cherry red spots, we can ideally go and come out. But if the patient is retching, definitely it's going to be a
that's why I make a point. Any chronic liver disease patient, especially you suspect varices, give preemptive ondansetron. We give them beforehand. Have a venous access, give ondansetron. In case if he is actually bleeding while you are doing a procedure, give a terlipressin available at least in your pharmacy. Try to give that also. So medication should be around and it might rescue you. What's your view, Kanagvel?
The sir has very clearly highlighted about the importance of avoiding. Now, having gone to it, once you have a bleeding in place.
Yeah, you pass the scope, bleeding happened.
Sheared and varix, which is very unlikely to happen unless the patient is very violently retched out. Or
yeah, that's
something.
what the reason.
The next thing which can happen is the on-table malarivis also is possible, especially when your scope is flexed and patient retching up. The other thing bleeds, which you have very rarely noted, is when the patient coughs or becomes little uncomfortable when you have the scope in D2. Usually duodenal mucosa are very fragile, they tend to bleed. Most of the time mucosal bleeds, unless there is background of portal congestive gastropathy or something, bleeds are self-limiting. Unless you have definitely poked with the accessory out of the tip of the scope, you are reasonably safe. Most of the time, if you have sheared the mucosa, just give the scope pressure over that for a few minutes, it stops. But if you are punctured with the biopsy forceps out or with the needle out, then you will have to play it very safe. Immediately pull out the needle, make sure you have closed the biopsy forceps, or if it is in an open position, ensure you assess what is the position it has punctured and where it has punctured. Depends, especially when you do diurnal biopsies. Sometimes people attempt to do diurnal biopsies with straight viewing scope. I have faced once, the resident, something went wrong. He advanced the biopsy forceps without any control. Luckily, it didn't damage much, but it was just next to the ampulla. It went inside about 1.5–2 centimeters. The point is, we were just worried whether it could have gone and damaged some vascular structures. Obviously, the superior mesenteric and the venous structures are close by. God, touch wood, nothing happened. This is the only one bad experience I have. Otherwise, if you are handling biopsy or if you are handling accessories, you will have to be extra careful. Preferably, if you feel the patient is not cooperating, have an anesthesiologist undo. There is one thing apart. Nothing is there, you have encountered bleeding. Usually the fundic varix is the one when you touch it and it continues to bleed. You have to call for help or you have to initiate other steps to reduce the portal pressure.
As I said, we are talking in the perspective of the beginners. I think they have no competence of how to tackle. So the best important, recognize the problem, call for help, rely on some pharmacotherapy. And if you insert the scope beyond the esophagus, retching and esophageal bleeding, usually the tamponade effect to some extent will come down, because they are all venous ooze. So if you are in the esophagus, patient started bleeding, you don't take the scope out. You go further into the stomach, wait, ask your nurse if they have terlipressin, you ask them to give 1 milligram terlipressin. It will decrease the flank neck pressure. I feel it is quite a useful drug. And definitely injection sclerotherapy, banding or glue injection, they are all recommended. In experienced hand they may handle. But for a beginner, the best thing is to seek help, and whatever they give, recommendation you give. The last resort, even though it is mentioned in the book, very often we don't use it, sense taken Blackmore tube. At least you should know that tube sometime will come to a rescue. That what people supposed to, beginners, they just like a Riles tube, pass it, inflate it and hold it until you have some help or transfer the patient with a sense taken Blackmore tube. So these are all the things we can, tackling an unforeseen bleeding. Okay. And next is of course a perforation. Can perforation happen in a diagnostic endoscopy? Yeah, 5 minutes. The last question, we'll keep it like that.
Very unusual, but it can happen.
Yes.
Especially you have shown that places, in these type of cases, if you are beginner and you are too enthusiastic, so your chances are there. Always be very careful, be very gentle and don't put extra pressure. All those who are helping me to the morning are saying go very slow and don't put pressure.
To prevent perforation during dilatation, any recommendation, Satish? When you are going to dilate, I don't want to see a perforation.
Firstly, we must assess the case, that how tight is the stricture, how much we should be able to.
What is the philosophy of dilatation in your hands? If you are going to dilate, how much you will dilate? How far you will dilate?
Just will dilate.
So rule of 3, all of you should remember rule of 3. So if it is a 10 millimeter, like 3 sizes, 10 otherwise there will be definitely chance of laceration, esophageal injury is high. And what is the first symptom of patient having a perforation? How they present to you? If you have done the dilatation and you see a patient and you suspect perforation, when you do that, when you suspect perforation?
Initially, if there is a minor, they can have pain, they will have the respiratory symptoms, breathlessness will be there. It depends whether it's associated with mediastinitis is there, that can also present. So, we have to be very suspicious if we suspect perforations. Smaller ones can be managed conservatively, but if they are big perforations, if there is soiling, then we have to go for surgery also.
Thank you. So, to summarize as such a complication, I think take home message is there are 3 complications you remember. As far as the upper GI is concerned, the commonest complication still is pulmonary. There is hypoxia, respiratory related. So you have to make careful how you monitor the patient to prevent hypoxia. Whereas as far as the colonoscopy is concerned, perforation is a real possibility. And whereas ERCP, pancreatitis is a real possibility. All three P's, pulmonary, perforation and pancreatitis. You remember that?
Surgical emphysema in the neck is the
that is
clinical picture that you get.
So always we have to have some protocol to prevent complication. I have just enumerated, for lack of time I am just rushing in. So we need to have a very strict protocol, how we disinfect the scope, how we train our staffs, how we monitor a patient. So all these things are very, very vital, and the question of antibiotic is one important thing I wanted to just stress here. Will you give antibiotic? A patient comes, he is having a congenital heart disease, he is coming for diagnostic upper GI or colonoscopy. Whether we need to give antibiotics? What is the reason advances say? No need. If you are going to do any intervention like dilatation, banding, one dose of cefotaxime is recommended, otherwise there is no need for antibiotics, even if they have cardiac conditions. And the next is when you have the anesthetist in the OT, because we always, when we give, for example, when you have children, we have ASA grade 3, or when you are going to do any therapy or things are happening inside the OT, main OT, I think you are expected. If it is in an outpatient setting, and you have so prove your competence that you have, usually that is a routine practice, and if you are using common drug like midazolam, I don't see you will be penalized for not having anesthetist. What's your view? If I am using midazolam, something mischief happens, but whether you will be penalized for absence of anesthetist?
Usually not, usually not.
Thank you. And this is the last slide. When you have into trouble, the main thing is avoid trouble by always be vigilant. You have to be very prompt recognizing a complication. Next important thing is never run away from the patient, very important. When there is a complication happens, be there, very important thing. Very often what will happen is you afraid to face the patient or relatives, how to explain, but you need to be very, you have to rehearse this, be present, be frank, compassionate, document everything, okay, because that is going to speak for you. Whatever you speak to the patient, this is what going to speak from tomorrow to the audience, everybody. And investigate, involve your seniors either at the same campus or elsewhere or across your mentor, these things. And always you have an audit in the last 100 cases, 200 cases, how many you had problem. That will give you an idea where you stand compared to the other standards. So these are all like now overview, bird's eye view of the complication. I think we can go on because the big topic as it is, just to sensitize you that this is a real issue. We need to protect our patient safety, surgeon safety, both we need to address. Okay, that is the way. And I thank all the panelists for having this short panel discussion. Thank you very much. Thank you.
Respected the seniors of Efiages and the delegates of today's session, it is a privilege to me in front of Dr. Stock giving a talk because he is a first pioneer and the first father of the endoscopist in South India in 1982. Yes, sir, is right. At that time I am a PhD student. I they are very passionate that you want to do it, and it's a privilege for me to talk in front of you. See, the endoscope is a looking through the glass. It's nothing but a glass fibers, which are fiber optics. The instrument and apparatus and implement of the machine and conveys an implant to uterine region and reagent or other similar and related attitude, including the component part of an accessory that is intended for the use of diagnosis of a disease or other conditions known are the cure and migration and treatment and prevention of the disease of man or other animals. The philosophy of the endoscope through the ages, and the endoscopy is a automobile car without the windows and the steering. Headlights, sorry. Steering is there to up and down and left and lateral. And that the primitive endoscopy, the first endoscopy developed in 1806 by Philip Bouzy in Metz and Lister. The light is conduction for the examination of the canals and cavities through the human body, that is, it looks like that. The first endoscope uses electrical light, the major step in the improvement of the endoscopy. The first such lights were the external, and later the smaller bulbs became available, making the internal lights possible. The evolution of endoscopy is the lenses and optics and the illumination and cameras and the orifices. And the lenses and optics, the first endoscope system is developed by the Philip Bouzy and contained to mirrors used to reflect the candle lights. At that time there is no lights and they are using candle lights to the internal organs. And the rods and lens system afterwards developed, that Harold Hopkins 1967 he devised the optic system and used the large quartz rod shaped lenses, and not only for significantly enhance the total image quality and image projected to the eye, but also the device still used to modern day scopes, that Hopkins system. And fiber optics, in 1970 the Hopkins quartz rod lens has been evolved into the flexible fiber optics made from the thousands of glass fibers. Hopkins fiber optics are developed by the heating of the segment of the glass rod until it is molten and then stretched rapidly to create a thread like fiber to alter the physical properties like this. The illumination, the important also illumination most important, the early era, the Italian researchers called Girolamo and Cardio, known for the mathematical skills and the medical work, developed the mechanical lantern to use the dark internal of the body. And 1729, army surgeons from the Britain named the Archald and Clarendon developed the biconvex lens documentation shown that used the biconvex lens light and directly magnify the light of the candle in order to look into the nose. And mid 80s and next most revolutionary by the illumination by endoscope, there will be visibility of the internal of the organ. 1983 connected for the these bulbs called the Mignon lamp, or the smaller filament light bulb at the distal tip of the scopes. That was perhaps for the first illumination scopes, and truly did not be need the cooling and therefore could be used as is. In the 1900s, the major revolution is by Carl Schwarz. 1960, he developed Palmar Koch rods and Hopkins rod system produced that can be called as a optical official first of the cold light technology. Schwarz combined with the transformation of the ability of the Hopkins fiber optics at the application of the Palmar quartz rods produced the light source and specially designed for the external forceful flash system and illumination outside the body. The unified system is produced the most detailed and clean imaging in history. The cameras, early cameras, John Kans and incorporated a device of the take photograph endoscopically, a practice that doubled in the stereopodic photography. And 90s and 1900 and 19th century, the 20th century, the saw and reinforced the endoscope into photographic powers, and 1934 the inventor of the Carl Scourger and able to produce the first photographic image in the uterus by attaching the own camera and designed as a histoscope. 1970s showed that the real shift of the surgical techniques all away from the open surgery and into the realm and operative video and video endoscopy truly emphasized for all the aspects of the minimally invasive philosophy as intended. Operation by the video monitor allows the minimal invasive surgery to be set free from the hundreds of the hair cysts of the and nearing the directly through the tube and spatula and scope. Modern age of the miniaturization and color film and video endoscopy became available by 1972, and the setup include the fiber optics and could be transmitted with the microscopic image as 8.5 kgs and there the 3 tube video camera. The next step of the camera is technology and continually improvements of the computer and components inside, and one such example is change into single chip camera and components into 3 chip design. William Chong and the collaboration of the Stryker and first to take the existing the 3 chip camera in almost in 1989 onwards. The tubing is one of the most important and to make the flexibility, and early era tubes are perhaps the simplest and component like the compromise the endoscope. The first endoscope in the house lens were by enhanced and rigid metal tube, and instead of the endoscopy took the rigid metal tube as a manipulate to a house new optics and illumination. And Pyris Solomon and Segels took the first step to changing the basic metal design tube to the early 1980s, and Segel has changed the tip of the scope from the rigid metal scope into the gum like elastic material. In Germany, a few years Alfred Kussmaul and designed the improved the access in the body in 1968. He enlisted the help of the professional swallow the sword swallower in the hopes in learning how to navigate through the body most and treacherous and counters using the Desmos and the gas casing lamp and illumination, and Kussmaul invented the custom of 47 millimeter long 13 millimeters in the diameter being the speculum. It took much more years to be attached. That camera became a flexible design as a flexible tube and could be attached to the camera. Modern age 1924 fluid and the desire to patient to safety and roll of designed as totally flexible scope, and semi flexible scope then be manufactured and marketed by Wolf company and boasted the features like and sensors and order to eliminating the stomach and soft soup decrease the things. Looking the feature that what is the next feature of the things are that the aeroscope. The aeroscope is equipped with a front facing camera and 360 degrees panoramic view and for viewing the side walls of the colon. Upon the insertion of the balloon as a anal sphincter is inside to make the colon airtight, and 2 balloons mounted in tip of the scope and inflated the CO2 gas to provide the cushioning and all sounds that the colon equal to the 360 degrees angle. And endotics, the endotics endoscope draws the inspiration to locomotive principles of the inchworm, and it is the 2 anchoring points, proximal and distal point, and automatically and activated using the vacuum suction, and middle section can able to contract and expand and along as longitudinal axis by cycling between the 2 actuation mechanisms. They are capable to inching forward the backwards. And invertoscope, the invertoscope aims to be lightweighted single use of the colonoscope that address the metal tip cross the contamination and from improperly sterilized endoscopes. It has a robotic hydraulically actuated for the navigation and retrograde viewing for use of the novel way of the advancing through the colon being surrounded by the air-filled and inverted sleeve that cushions the lumen of the tip of the moves forward. This theoretically reduces the almost force exerted by the colon. The NeoGuide endoscopy system recently acquired by the Institute Surgical consists of 16 individual segments that can be programmed to change the shape. As the lead segment makes the deeper into the colon, and rest will be automatically change their shape of the to follow the path that has been defined, and each that 16 segments has the 2 degrees of the articulation. And Plex robot system is a short flexible endoscopic designed by the transvarsal surgery. It is a over tube and comparing many ball and vertebral segments. Articulation achieved by the motorized tensing the cable tendon system, and that runs through the over tube and houses the video camera and at the distal tip. Due to the inner spine can be stiffened and able to maintain the shape of the path is travelled, like that will be there. And eye snake, the eye snake is be researched in Imperial College of London as a short flexible robotic tool. It has 6 segments by the mobile joints and micromotors, and embedded with the segments enabled to move the degree of the freedom and using the minute and gears and pulleys. Commercialized under the company of the Endomaster, consider custom developed endoscope has been integrated video scope and the instrument channels. The instrument channels support the variety of the instruments which able to articulate and electrocartridge stools and 70-degree freedom graspers. And Wyckoff, a flexible cable and robot initially developed with the endovascular and urological inventions, and also to be field of the gastroenterology. And it consists the steerable and over tube that houses the standard endoscopic and 2 instrument channels. It shares the control of the interface of the actuation and mechanism and a robotic assisted laparoscopy system, and marketed by the same company to facilitate the changes. See, the technology is changing, and the general surgeon is getting defamed or maybe completely vanishing from the situation, because you are losing all the things. Some gastroenterologist coming taking something, and cardiothoracic surgeon taking something, neurosurgeon taking, the previous general surgeons are doing. To make a survival, the general surgeon should be evolved today. The endoscopy is the right of the general surgeon. It take fortunately, unfortunately taken by the medical gastroenterologist, and the father of the endoscopy and Kestrau and IAGS, and made the availability to the general surgeons to make the wake. Unless otherwise, future the system is a endoscope doing the things, and like a laparoscope, the endoscope revolution also will come. Please take care and take your practice and take to benefit to the students and patients. Thank you.
I think now I'm well known to you, at least for a few days. So we did our colonoscopy basic, and today we have shown that we can go nicely up to the IC junction, go into the ileum, and now, as Dr. Rao has already shown, is venturing into newer and newer places. So we must update. Another point is very important, we must update ourselves. Whole life is a learning process. As we are saying, 50 cases, 100 cases. Actually, we go on improving if we want to improve. If you are complacent, after 50 cases, you mark yourself as a, today you are a specialist, 5 years down the line, you may be less than a general practitioner, because the world is changing. With that, I start this future of our endoscopy. We have actually focused not on the different magnifications which are very much in vogue, and we are using that one. The very first is chromoendoscopy. The last day we have mentioned part of that. Then water method of colonoscopy also have mentioned. Then we are going into the newer technologies one by one. Chromoendoscopy as is the oldest one out of the others. When we started our white light endoscopy, you should know the one thing what we do, the routine endoscopy is a white light endoscopy. I am mentioning, I have seen people done more than 1000 cases, even don't know that it is a white light endoscopy. So we try to be little academic at least. So chromoendoscopy, first what happened, when you see a suspicious place, then you try to highlight that area and to be more specific about our biopsy, so that we get, because if the biopsy shows the negativity, we have a complacency that there is nothing, and later if it comes out, we are doing injustice to the patient. So first one what we did, that there are different type of stains, absorptive stain, contrast stains, reactive stains, this indigo carmine, this contrast stain which is there. That is very important in cases of dysplasias in IBDs, where there are the whole colon is at risk. This is the one which we use in congregate. Some of the cases we use the whole battery of things. The absorptive stain has the affinity for a particular mucosa things. The Lugol's iodine we use for non-keratinized comb. Thing that is called electrochromoendoscopy, that is a narrowband imaging actually. This water method of colonoscopy is one. Yesterday I mentioned, I'm mentioning a little more. During the water method of colonoscopy, the colonoscopy distends the colon with warm water, means lukewarm water, and performs the examination with an underwater view. The newer colonoscopies with an integral water jet permit the rapid filling of the colon. It is postulated, few of the publications actually showed, that the water load reduces the angulation of the sigmoid and relaxes the colonic musculature, so that the intubation is mechanically easier. You have seen that during the flexures actually we were struggling to go into that. If the angulation we can reduce, it becomes easier. And then however, the process of water infusion is slower than the gas insufflation, and the overall procedure time is increased, but the water method has resulted in lower pain scores. Few large series have shown higher cecal intubation and a reduction in sedation drug demands. It is low cost also. In some studies, the water method is associated with higher adenoma detection than the gas insufflation, but this remains controversial. So ultimately, we are coming to the electrochromoendoscopy. It's a narrowband imaging, is the imaging technique for endoscopic diagnostic medical test, where light of specific blue and green wavelength is used to enhance the detail of certain aspects of the surface of the mucosa. You know the basic three lights are there, red, blue and the green. What we do, we put a filter so that the red part of the wavelength is cut off. So first we do a white light endoscopy, we go to a suspicious place, then put a filter by press of a button, and then it comes. Now we can see only with the blue and the green light. What it helps? And first thing is NBI is registered technology for the Olympus Corporation, his name is NBI. The same is known as FICE for Fujinon and iScan in Pentax. So those are all the same technology. And history of NBI, the idea of NBI was first conceived in 1999, and together with Dr. Sano of National Cancer Center Hospital, East Japan, the first generation of the prototype was developed. What is the importance? Importance is the targeted biopsy, as you said, for a better yield. To avoid the unnecessary biopsy. If you can see the peat patterns, then you can avoid the unnecessary cases. Then acute delineation for a complete resection. In few of the polyps, we have seen that the dysplasia goes little beyond their base, and also is not uniformly dysplastic. So from NBI we can also make out, and then we should take a little more tissue. We do as I do, I put a little normal saline, inject in the submucosa, take a little tissue up, then with snare we take out all the suspected areas. Otherwise you do a polypectomy, you leave behind some dysplastic area, and that can grow up again. See, that's we have shown what are the things. The NBI image on monitor, capillaries on mucosal surface are displayed. Are displayed in cyan color. Now, magnification is also important with the NBI, further increases the effectiveness of a substitute for the careful examination of the mucosa. As I have said, the first step of detection is done under standard vision in the white light, and to differentiate between the potential lesion and artifacts that are then characterized. Now, characterization, configure the lesion under standard vision and then use the chromoendoscopy to subtype the neoplastic lesion. Identify the microvasculature of the lesion using NBI. The alteration of the pattern of subepithelial capillaries are also classified as slight or severe. AFI provides an adjunctive white field technique to white light endoscopy. It highlights the neoplastic tissue without administration of exogenous fluorophore. Previously, we could have given the fluorophores IV, and then with special technique we can see the things. Now, from the endoscope itself, it goes and get the reflected thing, and you don't have any hazards. So, tissue fluorophores are excited on exposure to short wavelength light, what we are pushing, leading to emission of the fluorescent light of longer wavelength. All the tissues are not fluorescent, all the tissue doesn't liberate fluorescent. The tissue fluorophore in the GI tract include tyrosine, tryptophan, NADH, FAD, elastin, collagen and porphyrin. And the biochemical composition of the collagen and the perfusion of the tissue plays a role in autofluorescence. What happens when the tissue is going towards neoplasia, when the tissue are having the inflammation, this composition of the fluorophore also changes in the tissue, and that changes is reflected in the emitted fluorescence, and that we measure and we interpret it. So, malignant transformation of the tissue is associated with the emission of relatively longer wavelength of light, shift from green towards the red end of the spectrum, and dysplastic lesions are displayed in brilliant magenta color against a green or cyan color normal background, and the non-neoplastic tissue appears green. And that is how it comes out, and this is going out. That is the normal green color which we see in AFI. And this is not properly very nicely appreciated, but this is one area where that magenta color is there, and that was the suspicious area. Now we are coming to the next one, is endocytoscopy. What is endocytoscopy? Endocytoscopy is a magnification we are using. So, almost with endoscope we are doing a under microscope test. Again, you should have a learning phase, you should learn how to interpret. We are not, in third year we have learned some of the pathologies, so we have to learn how it looks in the endoscopies. The endocytoscope is passed through the accessory channel of a regular endoscope. That is another important. Others are we are doing at different endoscopes, NBI, autofluorescence, but here we are passing the endocytoscope through the accessory channel of the regular endoscope or colonoscope, and the tip is placed in direct contact with the surface after application of 2% methylene or toluidine blue. So, here we are staining that tissue, and on contact it provides a real time 450 time magnification, allowing a cellular level observation in vivo. And endocytoscopy is useful for detection of dysplastic cell, but the scan is limited to surface. The only problem is, and do not provide any information about deeper structure or depth of penetration, that you can make out, because we are looking from the lumen. And the next is the confocal laser endomicroscopy. What is that? Confocal laser endomicroscopy puts the power of microscope at the tip of the colonoscope. A low powered laser is focused. So, different places, different radiations and different wavelength energies we are using. A low powered laser is focused through a lens at a tissue target, and the same lens is used to collect the reflected light, and the point of illumination and the point of detection are at the same focal plane, justifying the name as confocal. And that is how we give the light, gets getting reflected and coming out. See, that is the point here. This is the area where the confocal imaging window, from where the laser is emitted and laser is collected. See, that is the area, that is the end of a place. And that is again you have a learning curve, you have to learn that how to interpret these things, these laser windows. The round crypts are there, structure, dark globulate cells are there. These are the points with which you can make out. This is the normal one. This is the hyperplastic poly, where crypts with slit and satellite openings are there. I am not going into details because it is a learning curve, you have to learn it. And that is the other, how the adenoma looks there, and how the adenoma, these are the carcinoma looks there. These are adenoma is wrong, that is adenoma, and that is the carcinoma, how it looks like in our CLE. And the last one is coming, is in the vogue, is the optical coherence tomography or the volumetric laser endomicroscopy, OCT or VLE. Like the endoscopic ultrasound, this OCT or VLE enables the cross-sectional imaging by a probe-based technique in near real time with high resolution. Instead of the sound waves, OCT image is formed by the reflected light from the tissue. As I have said, even in endocytoscopy, we cannot say the infiltration or depth of penetration. We are seeing only the superficial layer. Here we are going inside also. So some ideas about the infiltration of the tissue is also there. We are using OCT has a high resolution but poor depth tissue penetration compared to endoscopic ultrasound. Now OCT probe can be again passed through the accessory channel of the endoscope and can be kept in contact with the mucus of interest, which allows only points are there. If you want, it's coming. Already these are in our country. So in near future or a little few years later, you may be forced to go update yourself, anyone which you are passionate with. I hope this is giving you an indication the which way we are going very fast. NBI, I have done more than 1,000 in Athens this year. I was in the Greece conference. I was asked to give a North Indian, the East North Indian experience of 1,000 cases of NBI. But we got extra things. So with that, I request all of you, be passionate with your endoscopy. And as Sad has said, most of our things are they have snatched us from us. So we should venture also with lots of vigor and with lots of skill so that we can have our place. Thanks a lot.
Thank you, sir. Now I welcome Dr. Satish Mida.
Thank you. Oh, sorry. So light.
At the outset, I would like to thank the organizers for giving me opportunity to attend this course in a wonderful place. First time I am visiting this place. We all know we had the exposure of the diagnostic part of the endoscopy, but the field of endoscopy has really widened and the new challenges are coming, and we have various tools in endoscopy, upper GI colonoscopy, ERCP, capsule endoscopy, EUS, enteroscopy, and various therapeutic options are available. If it's not possible to cover all the fields, I'll just have a bird's eye view. In upper GI endoscopy, we can tackle GI bleed, which is a very common thing, and as a physician or surgeons, we will come across various situations: removal of foreign bodies, endoscopic mucosal resections, polypectomies, esophageal dilatations in strictures or achalasia, esophageal stenting, pyloric dilatation, and enteral stenting, just to name few. To talk a little bit about the upper GI bleed, it could be variceal bleed and non-variceal bleed, and therapeutic endoscopy has a great role to play in it. In esophageal varices, we can do banding, sclerotherapy, glue injection, and in fundal varices, we can inject the glue. Even in the non-variceal bleed, which could be of various these common conditions like duodenal ulcers, gastric ulcers, erosions, malarious tears, esophagitis, and many neoplastic lesions, or uncommon like diplophobia lesions, AV malformations, etc., and sometimes even iatrogenic conditions also.
we have various methods to control these bleedings. Most of these bleedings will stop by themselves, but in 10 to 20% of the cases, we really need to go in and do something. And we have various modalities like injections, some thermal means and mechanical means. So we usually employ local injections and sometimes the combinations of these. And we have to learn, and these are simple techniques, and we have to have the armamentarium and skill to provide this. So we can add organ plasma coagulation into our armamentarium and we can provide relief to many of the patients. These are the grade 4 varices. Sclerotherapy is now less used, but more or less we are doing endoscopic band ligation, but sometimes in the smaller varices, when the varices have come down to stage 1 and 2, and then we can use the sclerotherapy also. Glue injection, it is really a marvelous thing, and fundal varices can be tackled only by glue injections. Though it is not FDA approved in America, but still in most of the parts of the world this is being used. And banding gives the immediate relief to the patient and the veins will collapse. A patient has to undergo various sessions. Now we have multiple band ligators. We have seen the evolution of these bands through the years. When we started endoscopy, each band has to be put once, but nowadays the instruments have quite improved and they are very simple to learn also. A technician can learn it, and just you have to have, it is simpler than sclerotherapy. Duodenal ulcers, whenever you go in, you will see many times ulcer with active bleeding. Spurters may be there, and then you have to do something. You just can't leave it and let it rebleed again, and patient lands up in emergency again and again. And then many times there are strictures, corrosive strictures or strictures due to other benign causes, and these can be dilated by using balloons which are available. Foreign bodies is again a very wide spectrum area, and we have patients from all age groups, children, old age, middle age, and various types of foreign bodies you can think of is mentioned in the literature, starting from coins, dentures, and sometimes these may be life-threatening also. But with endoscopy, 90% of the cases we are able to remove, but sometimes if the foreign bodies are sharp or impinging on some vessels or something like that, then we have to go for sometimes even the rigid endoscopies, and many a time subject patient for the surgery also. Though this is a minor procedure, but it has to be done with great caution, because iatrogenic injuries, you can see metal clips, these pins and all, they can be swallowed by sometimes even by the psychiatric patients, children also. And coins, batteries, these are very common in our clinical practice, and we see day in and day out, and the patients are relieved from the major surgeries. It has to be mostly done under GA or under the presence of the anesthetist. Then we have stents. This is again, there are various uses of stents, especially in inoperable carcinoma esophagus. We can put in self-expanding metal stents. We have now biological stents also. We have various types of stents, stents for fistulas, stents to tide over some of the emergency conditions. Even in place of Sank's taken tube, there are now stents available also. Achalasia cardia has got various modalities for treatment, and one of them is the balloon dilatation, and where we can dilate, and it gives a good result, but sometimes there is recurrence also. The patient has to be explained that this is one of the modalities, and patient has to be given the options what he wants to choose, and there are different types of achalasia. Accordingly we decide, and some of the patients do very well with dilatation also. Colonoscopy again has similar indications, but mostly we get the polyps are quite common in colon, especially in children, and again we have polyps in adults also, and many of them are benign and some of them are malignant, so we have to identify them. We can do dilatation also with the balloon, and rigid dilatation can also be done. Colonic stenting can be done just to buy time if the patient presents with the colonic obstruction, and then we can go for the definitive therapy. And nowadays EMR and ESD is being done, and tomorrow we will try to cover it in detail. Polypectomy is really rewarding, and these patients, sometimes the children will also come with bleeding PR. Usually they have 1 or 2 polyps in the rectum, and it's just like an OPD procedure, but it has to be done very cautiously. Though it appears simple, but potential complications or side effects could be bleeding and perforation. So you have to be properly equipped with the accessories, always a good diathermy, and good assistance is also needed so that you can do this procedure. Endoscopic ultrasound, we'll talk about this tomorrow in detail, but this is again a promising tool for diagnostic as well as therapeutics in GIT, by which we can take fine needle aspirations, aspirate the cyst, pseudopancreatic cystinosis, celiac ganglion blockage, and staging of cancer and various other conditions. Now we'll talk something in detail about the ERCP, which is the thrilling therapeutic procedure which we are doing, and it has revolutionized diagnostic and therapeutic options in the last 2 to 3 decades. ERCP is a complex interventional procedure which combines science with art. It is one step ahead. After doing upper GI endoscopic and colonoscopy, to enter into ERCP you have to take a big leap. It's not just close by, and it requires lot of cognitive skills which take some time to develop. It is not that it takes a bit longer time, you have to learn it, and sometimes it is frustrating also because of the failures. And going back into the history of ERCP, endoscopic cannulation of the papilla was first reported way back in 1968. However, it was really put on the map shortly afterward by various Japanese groups working with instrument manufacturers to develop appropriate long side viewing instruments. And the technique was initially called at ECPG, endoscopic cholangiopancreatography in Japan, and then it came to Europe in 70s. Early efforts were held by multinational workshop at a European Congress in 1972 organized by Olympus Company. ERCP rapidly became established worldwide as a valuable diagnostic technique, although doubts were expressed in the USA initially about its feasibility and its role. And it was given a tremendous boost by development of therapeutic applications, notably by biliary sphincterotomy in 1974 and then by biliary stenting 5 years later by Nips Sohendra in Germany. And the name ERCP was coined in 1974, and Klassen performed the first sphincterotomy with his mentor Ludwig Demlin in Germany in 1973. Professor Kawai was the head of the endoscopic team in Kyoto Professional University in late 1960, like most of the Japanese endoscopists at that time. He was also interested in gastric cancer and other things, and he encouraged his young staff member Dr. Masazuku Nakajima, who became the primary pioneer in ERCP and sphincterotomy. So to develop an ERCP, you need a good infrastructure, not just a scope. Besides a different type of duodenoscope, you need a good fluoroscopy, a bundle of accessories which can be limitless like the things, a good energy source, APC, and you have to develop a good team which should be consistent with you. Then only you can do it. Each person has to understand everybody, and good anesthesia team as well supporting you, and then of course drugs and dye will be part of it. The essential prerequisites to do ERCP is the desire to learn it. You really need a motivation to go for this procedure, and then set up a team, and perseverance is always important. Scope, as we have discussed, is a different type of scope. It is a side viewing scope. The controls are same, but it has got an additional elevator by which we can elevate the instruments. Fluoroscopy is very important because it is with the fluoroscopy only, and you need to know interpret the fluoroscopic images also, which is left, which is right, when the patient is supine, when the patient is lateral, when the patient is prone. All this interpretation, which segment is being drained, these you have to correlate. And as I said, accessories are wide, and every day newer and newer accessories are coming, almost every day, and you have to keep pace with them because they are really going to help you. And radiological interpretation is important. You have to see these are the bile duct stones, obstruction, what is the level of obstruction, which side you have to drain. Otherwise, sometimes if you do not understand the pathology, you may harm the patient more by giving cholangitis or not draining a part of it, and the patient may land up with more morbidity and mortality sometimes also. Selection of patient is also very important for ERCP. It is not that some colleague of yours has referred the patient for ERCP and you will do ERCP. Many a times patients come to us with a physician advised ERCP. To some of them it will just appear that it's a OPD procedure like endoscopy. It's not like that. History and investigations are important, and you need to have a strong indication for ERCP. Nowadays ERCP is only done as a therapeutic tool, not for diagnostic. You have other modalities like MRCP and EUS by which you can complete the diagnostic part. And then you have to understand the comorbidities, anesthesia, and informed consent is a must like in any procedures. There are various indications for ERCP. The common ones are choledocholitis, pancreatolithiasis, acute biliary pancreatitis, chronic pancreatitis, acute suppurative cholangitis, papillary stenosis, benign and malignant biliary strictures, sphincter of Oddi dysfunctions, bile duct injuries, and hepatobiliary pancreatic ascariasis. There are few basic steps in ERCP. The first is approaching the papilla. This is the most important thing, that you have to approach the papilla with the side viewing endoscopes in a short scope manner. And then the second and the most important thing is the cannulate the appropriate duct. Whether you want to go for CBD or pancreatic duct, selective cannulation is a must, and then comes the procedure proper. Cannulation is 75% success. If you have cannulated the duct, more than half of the work is done. And then there are some body movements also you have to, which are very important. Then you have to set up an ERCP suit. Patient position is important, movements of the scope, and all these are very important. And it varies in biliary diseases as well as pancreatic diseases, which you come to know as you proceed with the cases. Click करिए तो video. Not playing. reaching. So this is the reaching the papilla. So when you go in, you are going sideways, you are not looking at the lumen, but sometimes you can twist and then you go to the pylorus, then go into the second part of the duodenum. Okay. And the papilla should come in front of you. And you should spend at least 1 or 2 minutes time, visualize the papilla properly, and then start the procedures. You just should not jump and start doing the procedure. Back to slides. And the ampulla is in itself a complex structure. It's not just an opening. There are various muscles, the associated blood vessels, and all these things you have to understand in great detail before embarking into ERCP, because sometimes you have to go for pre-cuts and all. Unless you know the anatomy, in which direction pancreatic duct is going, in which direction CBD is going, then only you can succeed. And this anatomy you have to always keep in mind, and the associated things, what are the changes in the diverticula, and all these things you have to keep in mind. So the relationship with the minor duct, major duct, sphincter, and all these things you have to keep in mind. And papilla in each case will vary. It will not be same as such. Sometimes it will be bulging, sometimes it will be flat, sometimes it will be at the edge of diverticulum, and so many variations are there, and you have to learn to cannulate each of them. This is the normal papilla, which will not be present in all cases. In 50% of the cases we get like this, but will not be something like this. Next video. And the cannulation, first cannulation. Cannulation and sphincterotomy, these are the two things. So you have to see, in this case we want to cannulate the CBD. So you can see our direction. We have adjusted the sphincterotome so that we are going at around 11 o'clock, between 11 o'clock and then 1 o'clock position. And as we go in, we just release the bow and we are in. So this is very important. And then the direction of the sphincterotomy is also important. And nowadays we have endoscopic cut in which there is a pulse of the coagulation and cutting. So back to slides. And then sometimes we have to put in stents also. So we must know about these stents, what types of stents are available, straight stents, pigtail stents. If we are not able to completely remove, then these stents are important. And we must have all these stents in various sizes available to us. Slides.
Endoscopic retrograde cholangiopancreatography is
you can skip that. This is again a diagrammatic representation.
Endoscopic retrograde cholangiopancreatography is performed using a side-viewing duodenoscope. The scope is passed from the patient's mouth through the esophagus and stomach to the descending portion of the duodenum. A wire-guided sphincterotome is advanced through the scope to the site of the major duodenal papilla. Cannulation of the major papilla is performed with the wire-guided sphincterotome. The position of the guide wire in the bile duct is secured, and the sphincterotome is advanced over the guide wire. The sphincterotome has a cutting wire that is used to cut the biliary sphincter segment using electrocautery. This opens the orifice of the major papilla to allow stone retrieval. A large stone has been identified fluoroscopically. A dilating balloon
or a basket and remove these stones. So nowadays size is not the criteria. We can dilate the sphincter with the CRE balloons and easily remove stones up to 1.5 centimeters. We can crush these stones, we can break these stones. We have got spyglass, and many a times if we are not able to access the papilla, then we can also give a pre-cut also. But pre-cut is not to be given by the beginners because of the potential complications which can occur with the pre-cut. Layer by layer we try to cut, and then we can, and sometimes it can cause bleeding also, and then we can access into the duct. Next. Now the role of ERCP in the era of lap chole, whether it has to be done pre-lap chole, post-lap chole or intra-lap chole, we had a small amount of discussion on it, but the consensus is that CBD should be cleared before lap chole, because sometimes there are incidents of failure also, then you can accordingly take the decisions. And we can remove these stones by with stone diseases, malignancy and benign strictures. ERCP is the only solution which as a surgeon also we can do it. In the past few years, the role of ERCP as a diagnostic tool has decreased with the advent of MRCP and endosono, and more or less now when we are going in, we are sure what we are going to do. It's not never for a diagnostic tool. Coming to pancreas, there are various indications like acute pancreatitis, chronic pancreatitis, pancreaticolithiasis, pseudopancreatic cyst drainage, malignancy, and in treatment of pancreas divisum. Again, it is more complex than the CBD stone. You have to understand the pancreatic disease more accurately, then only you will be able to do it, and sometimes multiple sittings are required. Again, you have to take into the cost consideration between the ERCP and surgical options also. Bile duct injuries which can happen even after open surgery as well as laparoscopic surgery. The incidence has increased after laparoscopic surgery, though it has come down after 30 years of lap surgery era, but still it is there. We still get cases, and it is a rescue it, and rather this is the area which prompted me when I was a surgeon, when we started doing laparoscopic cholecystectomy way back in 93, 94, we had some complications like bile duct leak, maybe small leaks, and we had to refer patients to other cities to do ERCP. So this inspired us to learn ERCP so that we could manage our own cases and start ERCP in our area. Sphincter of OD dyskinesia is again one of the area which is controversial, but it is useful in some cases. Hepatobiliary pancreatic ascariasis is quite common in our part also. We get dead as well as live worms in CBD, which can be easily managed with ERCP. Then there are special situations like altered anatomy, post-Billroth, post-liver transplant, sclerosing cholangitis, and biliary obstruction in chronic pancreatitis, which can all be treated by ERCP. Though ERCP appears to be thrilling, but again it is a procedure which has some morbidity and mortality, and it has got good complications which can be life-threatening. So it has to be done in a very good selected cases when you have everything like indications, setup and all these things and good training, then only one should venture for it. And two complications which must be mentioned are the pancreatitis as well as hemorrhage, which can be life threatening, and sometimes initially earlier when diagnostic ERCP was done, we used to get more number of pancreatitis, but nowadays, since ERCP is not being done as a diagnostic tool, the pancreatitic incidence has little bit come down, but it can happen with in any case. But with precautions, with less handling of pancreatic duct area, the incidence has come down. And we have to take it as a commandment that I shall not undertake ERCP in any patient, especially a woman who has normal LFTs, amylase or lipase and normal bile duct diameter, with the intention of diagnostic post-cholecystectomy right upper quadrant or epigastric pain, unless I have the equipment and training to perform biliary manometry. So you should not just do ERCP in any case. Complications, as I said, could be general, medication related, O2 desaturation, cardiopulmonary accents, hemorrhage, and selected to pancreatic biliary manipulations like pancreatitis, sepsis, hemorrhage and perforations. Bleeding can occur during the procedure, even after the procedure, and most of the time we are able to manage conservatively. I am here not to discourage you to take ERCP, rather I am to encourage you to ERCP, but you have to keep it in mind that it is a procedure which has got, in present era, many of the diseases can be tackled by minimal invasion, almost like an OPD procedure, but this requires 1% inspiration and 90%, 99% perspiration. So you have to really work hard to get into it, then only you can successfully perform this procedure. And there are newer horizons being added to the therapeutics in endoscopy. Now there are procedures in management of GERD, starting from radiofrequency ablation to various types of stitching equipments where you can manage GERD. Then third space endoscopy, it has again come in a big way, like POEM, and the horizons is increasing, and now you have removal of polyps, lipomas, etc. from the third space. It is rather being given the name of notes 2, the second edition of the notes, by which we can perform various other surgeries. And again, bariatrics is also coming in a big way in endoscopy. So in therapeutic endoscopy, the scope is really widening and sky is the limit. Thank you.
Thank you, sir. Now I welcome Dr.
Thank you for the disturbance. I would like to thank the organizers for giving me this opportunity, and I must appreciate the young surgeons who enthusiastically came to learn the endoscopy. As Dr. Ganebhaskar said, endoscopy is our branch. Unfortunately, it's taken away by the medical gastroenterologists, but we should take back that art. And I would like to thank Dr. Ganebhaskar garu to bring all the national faculty to here and conduct this magnanimous event. And I would like to thank all the faculty members for taking time and taking pain to come and attend this conference and teaching us the techniques of endoscopy. Thank you. Today, our topic is when to do and when not to do endoscopy. When to do endoscopy can be broadly divided into a diagnostic endoscopy and surveillance, screening, and therapeutic purposes. We see lots and lots of people with dyspeptic symptoms like upper abdominal pain, discomfort, nausea, vomiting, like those symptoms for which we need a diagnostic endoscopy to see the underlying cause. The other conditions, the following conditions like dysphagia, there are various causes for dysphagia which we can diagnose by endoscopy, and chest pain, which we need to be very careful before doing the endoscopy in chest pain. We need to rule out the cause of chest pain. If needed, need to give the cardiologist consultation and rule out any MI, and then only you do the endoscopy. Endoscopy is useful tool and gold standard in GI bleeding, and in suspected case of portal hypertension, we need to do endoscopy to see the esophageal varices, because in portal hypertension, 30% of people will be having esophageal varices, and if we leave them, can lead to catastrophic events. In unexplained weight loss and anemia, and if you suspect any underlying malignancy, we need to do endoscopy to rule out any malignancy. In chronic diarrhea, we need to do a colonoscopy to arrive at a diagnosis. And for chronic cough and recurrent aspirations, we need to see if there are any underlying cause, to see if there are any gastric outlet obstruction or esophageal obstruction. In inflammatory bowel diseases and familial polyposis, we need to do routine endoscopy. There are various causes for dysphagia, starting from achalasia, spasms, esophageal narrowing because of radiation, or esophageal cancer, or esophageal blockage, or esophagitis. GIT can bleed from oral cavity to anal canal. They either can vomit red blood or altered blood, or defecate a bloody stool or black stool. A small amounts of bleeding can lead into anemia. This is the diagrammatic representation of where all it can bleed, starting from oral cavity till the anal canal. Video. This is video. Press on the. Okay. The next use of the endoscopy is surveillance endoscopy. We need to do surveillance in certain conditions like Barrett's esophagus, varices, and GI malignancy. As you all know, what is the Barrett's esophagus? I need not explain. Is the stratified squamous epithelium of the lower end of the esophagus is transformed to simple columnar epithelium with goblet cells, which is the normal constituents of lower esophagus. And why Barrett's esophagus is important? Because it is a pre-malignant condition. These are the various pictures of Barrett's esophagus. in surveillance of esophagus, esophageal varices, the endoscopy is needed to eradicate the varices. We need to do once in every month to band the varices until they are vanished, and after that every 6 to 12 months to see if any new varices are coming up. In portal hypertension with cirrhosis, about 30% of cases with portal hypertension present with esophageal varices, and 30% of varices bleed in 2 years' time. Once if it bleeds, at least in 70% of varices rebleed within 2 years, and the mortality is very high with esophageal bleed. It is up to 15 to 50%. These are the slides showing esophageal varices. The typical 4 columns of varices are seen here. This is the plate of early esophageal varices. Here you can see the sinister sign of esophageal varices, which is cherry red spots, which impends the bleeding can occur, torrential bleeding can occur if you leave them alone. In case of upper GI malignancy, patient who had surgery, we would need to scope it in every 3 to 6 months time to see if any synchronous or metachronous lesions. If there are any local recurrence, we can diagnose it and take a biopsy from them. The other modality, we can use the endoscopy as a screening modality. In high risk patients, we need to do endoscopy, especially for family history of cancer, for upper or lower GI cancer. In case of polyposis coli, and we need to do a screening endoscopy, and in conditions like where gastric bypass is done in more than 10 years, we need to do screening endoscopy to see if there are any marginal ulcers which can lead into malignancy. This is opportunistic screening should not be done. As you know, what is screening and what is surveillance. Therapeutic endoscopy, in which gastroscope is used for the treatment of the condition. A procedure which is started as diagnostic endoscopy can be converted into therapeutic endoscopy. These are the various conditions where you can do therapeutic endoscopy. There are many conditions we can do, but few I'm mentioning here. Foreign bodies we can remove. Strictures of esophagus we can diagnose and treat them. Esophageal varices, fundal varices, antral gastropathy in portal hypertension, and polyps we can do polypectomies, and POEM, which means per oral endoscopic myotomy in achalasia cardia. The foreign bodies are common in children. Unknowingly they can swallow either batteries, coins, or sharp objects. Unfortunately, sometimes adults can also have the foreign bodies, like when they are intoxicated, like in alcoholic intoxication, or in psychiatric patients where they eat hair, we call them the trichobizar, things like that. Especially the sharp pointed foreign bodies to be removed, as they can cause perforation, and the flat batteries also should be removed. These are the various foreign bodies. So this lady was admitted to our hospital under our for laparoscopic hysterectomy, LAVH. The anesthetist, in repeated inquiry, she denied about the dentures, but unfortunately, because of the difficult intubation, the dentures were dislodged, and the patient has swallowed that. So we had to shift the patient to endoscopy suite and remove these dentures. In this case, polypectomy snare is used to remove the dentures. If they are blunt, it's fine, but when there are any sharp edges, we need to be very careful. Once if it is out of gastroesophageal junction, then the post-cricoid area is a bit difficult, then you can take it out. So strictures we can treat endoscopically for diagnosis and therapeutic purposes. Strictures can be benign or malignant. These strictures can be dilated with balloon dilators or Savary-Gillard dilators. With the endoscopy, we pass the guide wire, and with the help of the guide wire, we serially dilate with these dilators. Esophageal varices, the early varices and late varices, you get in portal hypertension. And for early varices, for grade 1 and grade 2, we can treat them with sclerotherapy, and for grade 3 and grade 4 needs banding. Okay. This is the post banding picture where the band is applied. This is the fate of the varix after 1 week after the banding. This is the fate of varices after sclerotherapy, few days after sclerotherapy. Fundus varices also can be treated with endoscopy. These fundal varices are submucosal dilatation of submucosal veins is in the fundal area. The glue is injected with butyl cyanoacrylate is injected. It is diagnosed in a J maneuver of the endoscopy. This is the J maneuver, fundal varices. You can inject these fundal varices with injector. Sometimes fundal varices can bleed. In this condition, we can either inject or inject a glue, or we can band it. This therapeutic endoscopy modality can be used for antral gastropathy as well. Fundal gastropathy can lead into acute and chronic upper GI bleeding. It is symptomatic in 15 to 20% of cases. This is the picture of fundal gastropathy. You can see snake skin appearance of the mucosa. There is another plate of gastropathy. Here the gastropathy is a bleeding gastropathy, active bleeding in gastropathy. Coming to the when not to do gastropathy, we can't do endoscopy in all cases. There are certain contraindications, especially if you suspect bowel perforation, you should not do. You need to do a erect X-ray of the chest and abdomen to see the air under the diaphragm, and if it is perforation is present, we should abandon the procedure. And patients with acute myocardial infarction we should not do. We should leave at least 3 months before we do endoscopy. And in case of respiratory distress, we should not do endoscopy. And in certain conditions, we need to take utmost care to avoid damage. Especially these are the conditions where senior endoscopists should do the procedure. Things like juncus diaviculum post-cricoid can perforate in young or new endoscopies. Corrosive poisoning, we need to do endoscopy between 24 to 48 hours to assess the condition, and you should not do it in full stomach. At least you need to give 6 hours NPO before doing an endoscopy. Uncooperative patients or violent patients, we need to give general anesthesia, and unstable patients, when the patient is bleeding, it is foolish to waste our time in doing endoscopy. We need to rush the patient to the theater. This is the repetitive thing. Since you are a bit tired, just thank you. That's all. Thank you very much for giving me this opportunity.
Good afternoon. I think last session before the lunch, I think everybody will be very hungry. This is going to be more of a video session. Just sit back and relax. I think already Satish has deliberated so much on therapeutic endoscopy. Following that, the local Dr. Reddy from Rajamundry has also deliberated on the therapeutic endoscopy. What all surgeons can do if they venture into therapeutic endoscopy or into endoscopy. It's just an overview. I'm just going to touch each and every topic. Mostly it's going to be the videos I'm going to show you. Just sit back and relax. And this has been already, all these aspects I'm not going to touch and elaborate on those. Only the videos I'm going to elaborate. And these are for the theoretical point of view, what all can be done by doing in the upper GI, in the upper GI endoscopy, what all the procedures that can be done by a surgeon, right from APC, dysphagia, stenting, SG dilation, salivary dilation, EMR, polypectomy, PEG, and in fact today morning I was telling to me in the live demonstration, PEG also can be done, and this is today morning which I showed. There was a vocal cord nodule. It's a very simple procedure. We identify it, you do a local anesthetic installation there and take a biopsy from this area. It's a very simple procedure. Don't worry about the bleeding, because you advise the patient that spit out whatever that is there in her throat, and nothing to worry about any aspiration or anything. And the same papilloma after it has been removed, where I have done a laser for the papilloma and it's been completely removed. And esophageal banding, it's a gross grade through to grade 4 esophageal varices. Here we are seeing the video of it. You can see nicely, and we are I think already there the banding, you can see the band that has been applied, and even though banding has been done, I would advise that you should all learn the art of sclerotherapy also, because there have been reasons where banding there is a torrential bleed after the banding and you will not be able to control the bleeding. In that case, you apply or you inject the varix, that is paravarically, where there is a bleeding, you inject paravarically and control the bleeding, like it produces a tamponade effect. And here it's a bleeding varix, how a varix bleeds. You can see nicely the bleeding. I think you can switch off this light, you can see that. See, there is a nice bleeding there, you can see. You can see the bleed is there. In this kind of bleeding, you are in a periphery, you are doing a diagnostic endoscope, there is a bleed there, and nothing to panic about it. If you have a band, get it ready. If you don't have a band, put the scope, like Dr. Ishwaramurthy said in the morning, put the scope into the stomach, wait for 5 minutes, get your anesthetist, put a line, start a IV drip, get his blood, what group it is, get a blood available, and then see, you can see the nicely the bleeding. Wait for 5 minutes. 80 to 90% of the bleeding will stop. If the bleeding still continues after 5 to 7 minutes, take out the scope. If you have a band, attempt a band. If you don't have a band, just send the patient to his nearest center where all the facilities are available. And this is how the banding is done for the same bleeding patient. You can see the bleed is there. I am trying to bland when there is an acute bleed, because this I am putting this video to say that even in acute bleed, banding can be done. See, I am attempting a band here. I am still at I have got the entire varix into my hood there. I am trying to install the band there. Once I install the band, see, I have installed the I have released the band now, and towards the end, if you see the bleeding has stopped completely. Whatever this bleeding, whatever you see here in the hood is, it's all the collected blood that's coming back to the hood. And the common foreign bodies, I think already Dr. Reddy had shown that, and this is another common chicken bone or mutton piece which you get in your day-to-day practice. It's very easy to remove all these things, and a common thing which you do in the practice is safety pin. If a safety pin is completely locked, it's easy to remove. If it's unlocked, the simple maneuver you do is reverse the pin so that the sharp end is away from you and remove the pin. That's what you have to do. This is what we do it here. You can see here in the video, the pin is in the first part of the duodenum, and I will reverse the pin. I will get it into the stomach, I will reverse the pin, and then I am using a snare here. See. After reversing, see this is how, after reversing the pin, the sharp end is away from you, then remove it. If you have a hood, it's called a hood, you put it at the tip of the scope. If you don't have a hood, nothing, it's very simple. Take a glove, cut the thumb of the glove, make a hole on the other side also, tie it to the tip of the scope. The scope, that hood will come out and it will form a sleeve over this safety pin. It's so easy to remove it. And as Satish was saying, esophageal stenting, it's one of the commonest procedure we do in our setup, because our incidence of cancer esophagus is very high in our center. And this is the CR view or the fluoroscopy view. Here you can see the stent there. We have got various companies which manufacture stent, the American companies, the Korean companies, the Chinese companies. And now towards when the stent is being released, make sure that the tip of the stent there where that's the release is being done should be within the see, you can see nicely the stent is being released, and that is the G junction where I have marked. If the growth is below at the level of the G junction, no way you can release the stent above the G junction. If the growth is in the middle esophagus, try to release the stent above the G junction so that you can avoid reflux. And complication of a stent, or in a case where you have a tracheostomy fistula, what is the other modality what you are going to do? The best modality and the only modality if the tracheostomy fistula is due to malignancy is put in a covered metallic stent, and the patient will be able to eat within 48 hours. You keep him alive for the next probably 6 months or 1 year. That's the best thing you can do. Or if not, you put in a peg or a patch. And here that's a nice fistula you can see. That is the tracheoesophageal fistula. That is the common. That is the esophagus esophageal opening, and the same fistula after stenting. See, this is the same fistula. I put in a metallic stent, completely covered the fistula. The patient will be able to eat well within the next 48 hours. And this is a stent which has been placed that is complicating and producing a tracheoesophageal fistula, because the stents which we use, the topmost portion and the bottommost portion is called the flare. The flare can produce and erode the esophagus and produce a fistula. This is called a tracheoesophageal fistula produced by a stent. So, what is the, how do you treat it? Either you put it a stent into a stent, or you do a patch or a peg. So, you can see nicely, that is what I am trying to show here is, I am putting a stent into a stent. Can you see? There is already a stent here. I am introducing another stent into a stent. Here I release the stent little bit proximal to the distal area, so that the fistula area will be covered by the second stent. And by this method we can make the patient eat for at least next till he lives. Because all these procedures are going to be palliative procedures. And for Barrett's, what are the things that can be done? APC, strata, and EMR. And the easiest way, you don't need any high funda equipment to do one EMR. EMR is endoscopic mucosal resection. Here you can this is the Barrett's. You have to take a biopsy to prove it is Barrett's. Once you have proven that is Barrett's, then if you know how to do a banding, that's a very simple technique. You can do a banding. See, you see a Barrett's area, you go and band that Barrett's area. You create it as a polyp. Once you band that Barrett area and create it as a polyp, then it's very simple. You do a polypectomy of that banded area. That becomes a EMR. That's the simplest way of doing a EMR if you are not having any other high funda equipment. See, here I am doing a banding of the Barrett's area. Once I do a banding of that area, sorry. So I've done a banding of that area. Once I've done a banding, it's very simple to do using a snare. You can do a polypectomy of that area. And for achalasia, what are the types of treatment available? Balloon, Heller's, poem. This is sorry. Yeah. How do you identify achalasia on an endoscopy? It will be a grossly dilated esophagus, number one, and number two, food residue will be present at the lower end of the esophagus. Food residue grossly dilated or a tortuous esophagus is a classical sign of achalasia, and you will not find it very difficult to pass the cardioesophageal junction into the stomach, because it is not a stricture. You will not find it very difficult to pass. You will be able to pass with minimal difficulty. You will be able to pass into the stomach. And just to complete it, I showed, as we are surgeons, we do endoscopic, laparoscopic Hellers also. Usually, when we do a Hellers in our setup, we always use an endoscopy at the time of laparoscopic Hellers, because we keep the endoscope in the esophagus and ask my assistant to switch on the light so that I don't cut through the mucosa, because the mucosa should not be cut, as you know, in the lap Hellers.
To preserve the mucosa, I keep there and I ask them to inflate it with air so that I don't cut through the mucosa there. You can see nicely the light shining there. You can see the light shining there. You can see the light. You can see on the live there, and make sure that the mucosa is completely stretched and there is no hole in the mucosa. So that if there is a hole in the mucosa, I can identify on table. You can suture the mucosa. And this is a poem. And poem is third space endoscopy. We create a small hole in the submucosal plane, go in the submucosal plane, and then you cut the sphincters at the sphincter level and extend it 2 centimeters below the cardioesophageal junction and 10 centimeters proximal into the esophagus. This is called a hybrid knife. This we use a hybrid knife in an RB machine. It's called an RB machine. We use a hybrid knife. It is what is a hybrid knife is, at the tip you have water. You can see nicely the water injecting. This you create see, this is the third space. This is one of the workshops done by Amit in during our last Efiages conference in my center. And yeah, this is a very nice video, and we were not able to identify the ampulla in the second part of the duodenum. It was completely shrinked and shriveled. Then when as we are coming out, we identify the ampulla. We identified the ampulla in the junction of the pylorus in the first part of the duodenum. There is a small hole in the junction of the pylorus in the first part of the duodenum. Then I cannulated it. It was entering into the CBD. It was not an anomalous ampulla as it's mentioned here. It was a distal CBD which was obstructed by a stone, producing complete obstruction, and there was a new pathway. The CBD has eroded. The stone had eroded into the junction of the this is the place, the junction of the pylorus in the first part of the duodenum, and formed a fistulous tract. And this fistulous tract opened, and the patient didn't have jaundice at all. And so I cannulated that area. So it was entering into the CBD. I cannulated the area. It was entering the CBD. I put in a stent there, and before putting in the stent, I removed a stone from there and put in a stent. And finally, the patient, he didn't come up for, because I wanted to do an MRCP to confirm that the distal CBD is okay. And as Dr. Satish was talking, we do still get a lot of bile leak after the lap coli, even after a post open coli. The commonest cause for a post open coli is when they do a CBD exploration. If you don't have a choledocoscope, there are a lot of 50% chance of missing a distal CBD stone, which can lie down very low level of the CBD. And one thing what all the senior surgeons say is, you put in an infant feeding tube, pass it into the duodenum. If the infant feeding tube goes into the duodenum, you are sure that the stone is not obstructing the distal CBD. That is absolutely not. I had many cases where they put in the infant feeding tube into the into the duodenum, and still there has been a stone. When you remove the distal, when the infant feeding tube has been removed, as they remove the stent, the stone gets obstructed in the distal CBD, and the bile starts leaking through the CBD explorated side. And then they come here. You put in a simple stent, ERCP, stent, stone removal stent. The patient goes home fine. This is a post lap coli leak, and half the video you will see. And I'm cannulating the CBD. I'm injecting the dye. As you see here, you concentrate in this area. The dye, there will be a nice gush of leak. See here, there's a leak here, and you can see the clips nicely. Simple. You put in a stent there. You put in 1 or 2 stents. Make sure that the stent, the proximal part, is into the intrahepatic biliary. Allow the stents for there for 3 weeks. And complete the leak will settle. Then remove the stents. This is a very nice case where the ERCP was done, and we were removing a stone. While removing the stone, the Dormia basket got cut in the CBD. So the Dormia basket is lying the CBD, the tip is lying in the duodenum. We were not able to take it out, and it got cut. See, it got cut here and it's lying in the duodenum, and we were not able to remove. The only solution is open up and remove it, or CBD exploration, lap CBD exploration, remove it. What we did was, since we had an ESWL in our center, we said that we have left an instrument inside the CBD, stating that instrument is going to break the stone. We have subjected the patient to ESWL for 2 weeks, and we went again, and the whatever this Darmia basket was lying the CBD gradually slipped out. We removed the stone and we removed the Darmia basket also. If you don't have an ESWL, the ideal thing is what you tackle is do a lap CBD exploration or open CBD exploration, remove the Darmia basket which has been cut there. Yeah. This is another case of post lap chole leak. You can see there nicely the bile is leaking out, and you can see the nicely stricture there. You can see the stricture is there, and here what you do is you put in a guide wire, pass the smallest stent which can be done. That is a 5 French stent. Put in a 5 French stent into the proximal CBD, then that's enough. The leak will stop over a period of time, and at least wait for a month and remove the stent, and the patient goes home without any more surgery. In this case, which I put here is, if there is a stricture, one stent will not be enough. You have to dilate the stricture. So what we do is put another stent after the patient comes back after a month, the next another stent after 6 months. So within 1.5 years, we are able to pass at least 3 to 4 stents, and keep that for a period of at least 6 months, and we dilate the stricture and remove all this. The patient again goes in for a stricture, you have to do either open or laparoscopy CBD secondary suturing. Exploration is done as reconstruction. And this is a fundic versus. And fundic versus is what we inject is a cyanoacrylate related glue. And the commonest mistake what you should not make is identifying a fundic versus as a small mucous lipoma or a polyp of the fundus, and try to do a biopsy of the fundic vertex, which is going to be a gross thing which will never mistake in your life again. This is a fundic vertex. Once you inject the vertex, when you remove the needle, it becomes solidified immediately within 2 to 3 seconds. You can see nicely it becomes solidified. Polypectomy. Polypectomy in various stages. This is a gastric polyp which you are doing. I'll show another real polyp which you remove. And gastroduodenal stent. Today morning I was showing a few of the people there a case of GJ which has been done, which is affected again, where we do a gastroduodenal stenting. This is a case of a gastroduodenal stenting on an elderly person where so you can see I put in a stent there in the gastroduodenal. This is a malignant obstruction. Instead of doing a GJ, I am putting in a stent there. This stent can be can keep the patient at least eating for at least next 6 months. This is an uncovered stent. If you put a covered stent, the only problem is it can obstruct the ampulla and produce obstructive jaundice. If it is an uncovered stent, the problem is the tumor can ingrow to the stent and obstruct again. So that happens within a period of 3 to 6 months. Then what you do? Then again you do a laser or organ plasma coagulation inside the stent. Bleeding duodenal. You can see nicely. You can see a nice bleeding duodenal ulcer. What do you do in this bleeding duodenal ulcer? What are the procedures you can do? You can inject saline, para the bleeding areas, or if you have APC, you can do APC, or you can do polydecanol. Polydecanol you can do, or a glue injection we can do. The same bleeding ulcer where we have done an APC. You can see the APC being done. That's an APC probe that's coming there. You can see the APC probe coming there. And the same ulcer, after a period of at least probably 10 days or 20 days later, completely the bleeding has stopped. Once you start them on proton pump inhibitors and IV, and we in our center we usually use this sucralfate solution. It's one of the best solutions to prevent a recurrent bleed. The lower GI indications as a surgeon, what we can do for using an lower GI scopy. Polypectomy, colonic stenting, and in the case of radiation proctitis. And this is a colonic stenting which we do. Like Satish explained there, colonic stenting stands as a stopgap between a definitive surgery. Or colonic stenting is the treatment of choice if the patient is elderly and patient can't withstand any major surgery. See, patient comes with an obstruction, he doesn't want a colostomy, do a colonic stenting. Here you can see colonic stent. Oh, sorry. This is a patient who had a ostomy done outside for a rectal carcinoma, but he wanted the ostomy closed, but he was not willing for any definitive surgery. So what I did was, through the ostomy opening, I did a retrograde colonic stenting. Once the stoma was fully patent, then what we did was close the stoma, that they call ostomy stoma, and the patient went home fine. And because he had multiple liver secondaries, he didn't live much long. Yeah, this is endoscopic resection, mucosal resection of a colonic papilloma. I will show you a colonic. See, this is a rectosigmoid colonic papilloma, where I am doing an endoscopic mucosal resection using a needle knife. You can see this instrument coming out. This is a needle knife. Complete resection we do, and completely we take out the tumor, and then we send it for a histopathology examination to look whether the base is completely free of the tumor. After resecting, I am using a snap to completely remove the tumor. This procedure takes minimum of at least 1.5 to 2 hours. So you need an anesthetist to do this procedure. This is a radiation. Common cause for this radiation proctitis, cancer cervix post radiation. Cancer cervix post radiation, it's very difficult to treat when a patient comes for bleeding PR. The common things which we do conservatively we do is enema. That is, enema is what enemas we give. It's entoform enema. Now, entoform is nothing but steroidal enema. We give steroidal enemas. If the steroidal enemas they don't satisfy, then we do is organ plasma coagulation. This is how the radiation proctitis looks. It's completely, the entire rectum up to the sigmoid colon will be full of erosions, and it will be bleeding. It will be a diffuse ooze. It will be. Here you can see what I am doing here. It's an organ plasma coagulation. It's a very slow procedure. You need a lot of patience. You need to do at least 2 to 3 sittings to completely fulgurate all the bleeding areas. This is how we do it. And already Satish had shown, this is how a stone. I am using a balloon here to extract a stone from the CBD. This is a huge stone from the CBD. This is a pigment stone. And this is another pigment stone which has been extracted from the CBD. And this is another stone where I am using a stone crushing instrument. What is a stone crushing instrument? It's called a lithotripsy. Here, this is a lithotripsy instrument which I am using here. Yeah, see, I have crushed the stone. It's not a globular stone. I crushed the stone and removed the stone here because it's not coming out. The stone size is almost 2 centimeter in size. I used this crushing instrument and removed the stone. And as previously mentioned, cholangiocarcinoma or Klatskin tumor, if it is inoperable, more of a palliative procedure is metallic stenting. Here we have got, nowadays we have got both covered and uncovered. This is an uncovered metallic stent which I have put for the Klatskin tumor here. And here is a periampullary growth. It's a huge periampullary growth, and the patient, it was inoperable because of multiple liver secondaries. So what we did was, because of the jaundice, I am doing here, what I am doing is a pre-cut. I am doing a pre-cut, and following the pre-cut, I am putting a stent there. See, I am passing a guide wire there, and following which, yeah, I put in this is not a metal stent, this is a regular plastic stent which I put there. Once the bile starts flowing, the jaundice comes down. And newer modalities, spyglass endoscopy. What is spyglass endoscopy? As Dr. Satish mentioned, this is the ERCP scope. Previously, it is called the mother baby scope. And in this ERCP scope, you introduce the spyglass scope. This comes out through this biopsy channel. You get into that. Okay. Yeah, get into this. You go in. You can go up to the intrahepatic biliary. You can flush the intrahepatic biliary. And you can not only flush that, you can do is, you can take a biopsy of the intrahepatic biliary. Nowadays we use in our center is biopsy, and you can even use a laser to crush the stones. I will show one of the videos where we are crushing the stone, how it gets pulverized. This is the stone that is being crushed here. This is one of the latest modalities which we use now in ERCP. You can see It's a holmium laser. It's a green colored laser. It's a holmium laser. It is shown in the right hepatic duct. Just watch the video as I it gets completely pulverized. And now double balloon endoscopy. Double balloon endoscopy. So to state that no part of the intestine is never, it can't be reached today. That's what for double balloon endoscopy is reaching the unreached. Here is a nice case of an ileal stricture. Ileal stricture, what we did was we identified the ileal stricture, took a biopsy, then we did a laparoscopic resection of the same ileal stricture. As you look, this is the ileal stricture area. This is the ileal stricture area. You pass in the biopsy forceps into that and then take a biopsy there and then confirm that it was a Crohn's. Then we did a minimal resection of that area because the patient had chronic abdominal pain. We did a limited resection of that area. The patient went home fine. To conclude and think, almost every part of the gastrointestinal tract can be reached except probably, I would say in my thing is the distal most part of the ileum is the only area which we are not able to reach most of the time, and that can be reached in the retrograde aspect, but many times we are not able to reach it. That is the last 10 to 20 centimeters of the ileum. Otherwise, most of the gastrointestinal tract can be reached and we can tackle it easily. Thank you.
Thank you, sir. So now we can go for a lunch. Please do the biometry, and next we have the simulation session. Please practice on the simulators because tomorrow morning you are going to face an assessment by the examiners at 10 a.m. in the simulation lab. Thank you.